Okay, this video is on gonioscopy. I guess this is the part 7 or 8 of gonioscopy, I don't remember. I think it is part 7 of gonioscopy. So we'll start with other uses of gonioscopy. The examination discussed so far has been focused on the detection and assessment of angle closure. Obviously, there is a wide range of other angle pathology that is of importance to the glaucoma specialists, such as pigment dispersion, uveitic synecdoche, and pigment damage, silicon oil droplets, and neovascularization. Experience a good atlas of gonioscopic pathology and careful gonioscopy should identify these. A few examples of non-angle closure pathology that illustrate the range of signs seen. Pigment dispersion causes uniform pigments throughout the angle that may be dense, obscuring the tubercular meshwork, or more subtle in pseudo-exfoliation syndrome. There may be pigment shading and patchy deposits together with deposits of pseudo-exfoliative material. Silicon oil glaucomas often have multiple emulsified oil droplets throughout the superior angle, not be confused with heavy liquid deposits in the inferior angle. Iris neovascularization has to be distinguished from simply dilated iris vessels and variants of normal angle vasculature. The abnormal vessels are fine branching vessels that cross the angle rather than running along the length of it, which are associated with peripheral synecdoche. In angle recession, there is an irregular widening of the ciliary body band. In severe cases, this may only be detectable with careful comparison of both eyes. Peripheral anterior synecdoche from iridocorneal endothelial syndrome can be dramatic. Lastly, cyclodialysis cleft in hypertenous eyes can be notoriously difficult to identify. The low IOP leads to easy compression and distortion of the cornea, with loss of clarity, and small clefts are often obscured by iridotubercular contact of even frank peripheral anterior synecdoche. It is sometimes necessary to inject viscoelastic into the anterior chamber to give sufficient chamber stability for successful examination. Easily overlooked causes of secondary glaucoma can be revealed by careful inspection at the time of gonioscopy. Finding a foreign body in an angle, seeing holes in the peripheral iris caused by the passage of an intraocular foreign body, observing a traumatic angle recession, appreciating precipitates on the tubercular surface, or recognizing blood in Schlemm's canal, suggestive of increased venous pressure or inflammation. If no obstruction and the tubercular meshwork can be seen, the block to outflow must be beyond the tubercular surface, and by default, the diagnosis is open angle disease. Use of mydriatics might cause the angle to close completely in eyes with narrow angles, precipitating an acute rise of intraocular pressure. If myotics become necessary for the management of glaucoma in an eye with a narrow angle, the angle should be re-evaluated after therapy has begun. Occasionally, myotics narrow the angle further as a result of forward lens shift and enhanced pupillary block. Therefore, in narrow-angled eyes, any change in therapy should be monitored by periodic and frequent gonioscopy. Post-operative examinations. Post-surgical gonioscopy. While it is possible to gonioscope an eye soon after cataract surgery, it is rarely necessary in the immediate post-operative period due to the risk of inadvertent compression, reopening of the wound, and possibility of infection. A sutured wound will of course be much safer than an unsutured section, but both have risks if compressed. If it is essential to perform gonioscopy, then very gentle placement of a 4-mirror lens, which requires less manipulation to insert and minimal rotation, can be safely used, for example, in post-tuberculectomy patients in whom the patency of sclerostomy must be assessed. The success of iridotomy in opening an angle and can be evaluated promptly by gonioscopy. After filtering procedures, The surgical ostium can be seen gonioscopically. If filtration is impaired, the appreciation of a patent ostium will directly attempt to restore the blade by addressing the episcleral surface, suture lysis, blade needling, or resections of scar tissue beneath the conjunctiva. If the ostium is occluded by the iris or adhesions, it may be reopened using laser. Conditions other than glaucoma. The diagnosis of peripheral tumors or cysts often can be made by gonioscopy. The extent can be determined by an accurate view of the extent to which the iris and ciliary body are involved, supplemented by anti-segment imaging with ultrasound biomicroscopy. Foreign bodies in the angle and holes in the peripheral iris from penetrating foreign bodies may be discovered. Inflammatory and traumatic conditions such as keratic precipitates covering the meshwork and erythrodialysis can be visually evaluated when a portion of the cornea is hazy. It may be possible by gonioscopy to look through a clear portion of cornea to see the reason for the haze. Tears in descemet membrane, epithelial downgrowth, and areas of vitreous adhesion can be diagnosed in this way. Cycloscopy. This technique allows direct visualization of ciliary processes under facial circumstances, such as the presence of an iridectomy, wide iris retraction, and iridia, and some cases of aphakia. Although spatial contact prisms with scleral indenters have been developed for cycloscopy, the procedure is still limited by the small percentage of eyes in which circumstances are favorable for good visualization of the ciliary processes. The main value of technique thus far has been in research studies of the ciliary processes and in conjunction with laser therapy to the ciliary processes, transpupillary cyclophotocoagulation, imaging, ultrasound biomicroscopy, and optical coherence tomography. Gonioscopy is limited by poor inter-observer reproducibility and the need to use visible light. Objective, quantifiable, and reproducible measures of the angle can now be achieved by ultrasound biomicroscopy (UBM) and anterior segment OCT. These can be performed in true darkroom conditions, and the resulting cross-sectional angle images are very amenable to automated analysis and quantitative comparisons. Ultrasound biomicroscopy and anti-segment optical coherence tomography complement rather than replace gonioscopy, however, which remains essential to assess peripheral anti-synecdoche, angle pigmentation, bases, and other certain angle characteristics. Conclusion. The diagnostic basis of any glaucoma should be in correlation to the gonioscopic findings, wherever possible. The management and prognosis of the disease depends on a complete diagnosis that includes a routine gonioscopic evaluation. Gonioscopy widens our scientific understanding of the disease process and guides us to manage the disease more effectively. The approach to gonioscopy that we have outlined here describes a clear, rational, and evidence-based technique to elicit the science of angular pathology. There is no substitute for carefully gathered experience and thoughtful reflection upon every patient examined. Only with practice do we become proficient, and only with practice do we improve. Now, figures and tables. Figures 12A to C, peripheral anti-synecdoche. Peripheral anti-synecdoche, these are broad-based and they are up to the shoulder base line. They breach the underlying structures, they drag the iris bases with them. So, how the peripheral anti-synecdoche, they are different from iris processes. So, iris processes are fine and lacy. Peripheral anti-synecdoche, these are broad and irregular. Then, extension, the iris processes are up to the portion of the trabecular meshwork, while peripheral anti-synecdoche, these are present up to the shoulder base line. Then, facial feature. Iris processes, they follow the concavity of angle creases, and peripheral anti-synecdoche, they breach the underlying structures, and hence they do not inhibit the movement of the iris in case of the iris processes, and peripheral anti-synecdoche, they drag the iris bases with them. So in figures 12A to C, we can see the peripheral anti-synecdoche. These are broad-based. They are up to the shoulder base line. They cross the trabecular meshwork, and They track on indentation, they track the iris bases with them. Figures 13a and b, gonioscopic view of prominent iris processes. Fine lacy for the concavity of angle recess, and these peripheral anti-cyanic, they breach the underlying angle recess or underlying structures. Now table 10, angle blood vessels, normal vessels and neovascularization difference. Normal vessels, these are radially oriented peripheral iris and circumferentially oriented in ciliary body. And these are thick, non-branching, they do not cross the scleral spur. And neovascularization, these are fine, branching, usually cross the scleral spur. New vessels, they are fine, these are branching and they cross the scleral spur. While normal vessels, these are either circumferential or radial. Radial in case of the iris because the iris is oriented like that, and ciliary body is circumferential. So vessels over the ciliary body, they are circumferential, oriented circumferentially. And normal vessels, these are thick, these are non-branching, and they do not cross the scleral spur. That's the difference between the normal vessels and new vessels or neovascularization. Now figures 14a and b. A. Gonioscopic view of the angle of the antechamber in an eye with pigmentary glaucoma. Note the dense homogeneous grade 4 pigmentation of the tubercular meshwork. B. Gonioscopic view in pigmentary glaucoma. Note the concave iris configuration. So B, we can see the concave iris configuration in pigmentary glaucoma, and in figure A, we can see the dense homogeneous pigmentation of the tubercular meshwork. Now figure 15A and B. The dandruff-like exfoliation material can be seen in the angle in eyes with exfoliation. The tubercular meshwork shows patchy pigmentation with pigment deposition anterior to the shawl base line, especially in the inferior angle. So tubercular meshwork is more pigmented than the normal in pseudoexfoliation syndrome or pseudoexfoliation glaucoma. But this tubercular meshwork pigmentation, it is not homogeneous like that seen in the pigmentary glaucoma. It is homogeneous. And here it is dense, but it is not homogeneous, it is patchy. And shawl base line, Sampao-Lazy's line. What is Sampao-Lazy's line? It is a pigmented shawl base line, or the line that is pigmented line that is present anterior to the shawl base line. It is seen in the pigmentary glaucoma, traumatic glaucoma, and also pseudoexfoliation syndrome. Now figures 16A and B. Gonioscopic view of the angle of the antechamber showing angle recession. Angle recession, you can see the wide ciliary body band. Figure 17, foreign body in the angle along with peripheral anterior cyanic. We can see. Figures 18A and B, gonioscopic view showing the haptic of the PCIOL in the angle. Okay. So here I conclude the gonioscopy series. Actually, I have covered gonioscopy from Shields first, then from Jacobi, and then from Arvind. So I have completed these 3 standard books for gonioscopy, and also I have referred the videos from and also added the videos from www.gonioscopy.org, and you should also see all those videos because there's so many nice videos, and rather than just downloading them and making it available for you here, that I'm gonna do anyways, because I'm gonna add pictures and videos along with the gonioscopy history after 2-3 days. First, let me complete the lasers in glaucoma in short, because we have seen the procedure of the gonioscopy, the principle of the gonioscopy, the other uses of the gonioscopy. So I would like to talk on the lasers, like anti-laser tuberculoplasty, selective laser tuberculoplasty, upon laser tuberculoplasty, ALT, SLT, then laser goniotomy, laser iridoplasty, laser iridotomy, then pan-retinal photocoagulation, because that comes in the treatment of the neovascular glaucoma, and yeah, and cyclophotoablation. That also I'm gonna talk. Laser cyclophotoablation. That also I'm gonna talk in laser treatment in lasers, uses of the lasers in the glaucoma. In that section, I think it will take 8 to 9 days, because every procedure will take 1 day, because I have to make short videos. It's taking a lot of space, and my mobile gets heated fast, so I have to make short videos, like not more than 30 minutes, so it will take 7 days. So first I'll complete the laser principle, how the laser is produced and how they interact with the tissues, what kind of interactions, what types of interactions of laser are there with the tissue, and how we use them in different procedures, in the different laser treatments. That I'm gonna talk. And different, yeah, seven, eight laser procedures which we use in glaucoma, that only I'm gonna talk. And then I'm gonna talk about panretinal photocoagulation. I would like to talk about the neovascular glaucoma also. Neovascular glaucoma, yeah, that chapter I'll read from either Shields and Arvind's glaucoma, and Jacobi also. So it will take 10 days, because 3 days for neovascular glaucoma and then 7 days for each laser procedure that is used in the glaucoma. Because I'm also gonna add laser videos from YouTube also, and from Gonioscopy.org also. There also nice videos are given on SLT and ALT, argon laser tremculoplasty, selective laser tremculoplasty. So tomorrow I'm going to talk about how the laser is produced, what are the properties of the laser, and the laser tissue interactions, and then and the chart, like laser tissue interactions and what kinds of lasers are used in short. If the time permits, it will take 2 parts. I'll finish it fast, but I don't want to like too fast and too slow. I want to have the moderate speed. It all depends upon my mobile. I wish I had a camera, standard camera. So because the mobile is it's putting lots of limitations on my work on video, audio, books, you can say. So otherwise I would complete it fast. Like in a day I would make 4 hours ka video. I would complete the gonioscopy in the same day from Shields and Arvind and also Jacobi. In 1 day only I would cover, but because I have less memory in my mobile and my mobile also gets heated very fast, so I have to make short videos that I do. So tomorrow we'll see how the laser is produced and what are the properties of the laser and what are the laser tissue interactions and the types of the lasers which are used in ophthalmology, and their examples. And in detail I'll be talking about each kind of laser, not so much in detail, each kind of laser and their uses the day after tomorrow. And after that I'll talk about the SLT ALT first from the laser book, which I have read already in my post graduation, that I'm gonna read. That book I really liked. I don't know whether it's the standard book or not, but I have compared it with other standard books, some pages, so the information is accurate. It's relatable with standard books. So I can refer that book, I guess, and I can just share my input, because it's very simple language and very nicely given, like point to point it's given there. So that book I'm gonna read for SLT, ALT and all the procedures. And for SLT, ALT I'm also gonna read Shields. For laser production I'm gonna refer Shields textbook of glaucoma. In that, how the laser is produced and what are its properties and laser tissue interactions. That also is given in Shields. So first laser, then laser types the day after tomorrow. Then on 3rd day I'll be talking about SLT ALT from the book, and then on the 4th day SLT ALT from Shields. Okay, so here I conclude my video, and thank you so much for listening to me patiently for around 20 minutes. Thank you so much and good night.